So, good evening, ladies and gentlemen. In today's live program, we discuss on innovations in kidney transplantation. I am Dr. Praveen Kumar Etta, nephrologist from Virinchi Hospital, Hyderabad. So, coming back to the topic, innovations in kidney transplantation. So, for general public, innovations, which mainly include the recent developments, we discuss the main things because the audience will be the general public. The actual in-depth medical things they may not note and they may not be aware of. So the general things and the recent developments in the kidney transplantation we will discuss. Okay. So before going to the actual topic, the background of the renal transplantation, first a brief note. So in kidney failure patients, there are three options of renal replacement therapies are available. One is hemodialysis, another is peritoneal dialysis, and the third one is the kidney transplantation. So compared to any form of dialysis, either hemodialysis or peritoneal dialysis, kidney transplantation is the best form of renal replacement therapy, because if we see the statistics of quality of life and the survival rates, they are better with kidney transplantation. If you see the 5-year survival rates of any form of dialysis, it's only around 35 to 40% survival rate at 5 years for dialysis. In case of kidney transplantation, the survival rate at 5 years is almost more than 95%, and at 10 years it's more than 80%. So the survival rates and the quality of life are much better for kidney transplantation compared to the dialysis. So the whole developments or the recent developments or the innovations, they are happening much more in the field of transplantation compared to the dialysis. And the transplantation is the best form of renal replacement therapy that we can offer to any patients with kidney failure. So in this today's topic, first we'll briefly review the current status of renal transplantation in India and across the world. If you see the Western countries like United States example, they do almost 12,000 to 15,000 transplants per year, and majority of these transplants, they include mainly cadaver donors or the dying person's organs. So the organs harvested before the death of the person, they contribute the majority of organ donations and the transplantations. So they contribute to almost 2/3 of all transplants. Whereas coming to the live donors, especially the related or unrelated live donors, they contribute only to the less than 1/3 of all transplants in the United States. In case of India, here almost 90% of transplants, they are from live donors, especially live related donors, especially from family members. Only less than 10% of all transplants, they come from actual dying persons. That is the cadaver donation or the deceased donor program. In last few years, even in India, because of streamlining of this cadaver donation program, even in Telangana, we have Jeevan Dan program. So because of that, the cadaver donations have become streamlined. So the deceased donor organs, they are now picking up in recent years. But even then, when compared to the live donation, deceased donation is quite in primitive stage in India. And if you see the various types of donations that are being implemented in Western countries, in European countries, especially Spain and Belgium, they follow opt-out system. Opt-out system of organ donation means the citizens of their countries, they are naturally or inherently, they become organ donors at the time of their death. In case of road traffic accident or any form of where there is a possibility of organ donation, they are considered as organ donors by inherently. Okay, that is the opt-out system. And in case of India, we follow opt-in system. Opt-in system means we are not considered as organ donors. Only one can have to give prior consent, either the patient himself when the patient was alive, or the attendants when the patient is dying. So somebody has to give consent for organ donation. Then only the organ donation process they start, and the organs can be retrieved before the death of the person. So we follow opt-in system. So by this is the one of the major differences why our organ donation rates and the deceased donor program is much primitive stage compared to the European countries. In Spain, the organ donation rate of the dying persons is much higher compared to the India. So, and coming to the actual topic, that is the recent developments or the innovations in kidney transplantation field. So these developments are happening mainly in three fields. So one aspect is to increase the number of donations or to improve the organ donor pool. So there are several developments happening or happened in this field. And the second aspect is development of newer drugs for transplantation. So in transplantation, we have mainly 3-4 classes of drugs which are currently being used. Induction agents like basiliximab and ATG are available, and the maintenance drugs like steroids and cyclosporin, tacrolimus, or mycophenolate mofetil, azathioprine, they are available. So they are currently available, and newer drugs are being in pipeline or in development, mainly because of their safety and lesser toxicity profile, and more effective or more potent drugs are in pipeline. So that is the second field of development or the innovations are happening in the field of transplantation. And the third field is the surgical technique. Okay, so in olden days, all either donation or the recipient surgery, they are in a much cruder way. Okay, and later on, laparoscopic surgery has come into the picture, especially the donor nephrectomy by laparoscopic route. Okay, and minimally invasive routes are now becoming more popular, especially the robotic way of kidney transplantation is now in the pipeline. So these three major fields are under development in the field of transplantation. One is the improving the donor pool, and there is development of various drugs in the field of transplantation, and there is the improvement of surgical techniques. Okay, so first we'll talk mainly on the improvement of donor pool. So nowadays we are taking much of marginal donors. So marginal donor by definition means these donors are not that actually good. Okay, so these marginal donors mainly they are also called as expanded criteria donors or ECDs. ECD means expanded criteria donor. So these mainly include the donors with age more than 60 years or age between 50 to 59 years plus two of the three risk factors like hypertension or creatinine more than 1.5 or death from stroke. So any of these three, out of them two are present, they are considered as ECD or expanded criteria donors. They are actually marginal donors. That means the donor kidneys are not that good. So in olden days, we used to discard those kidneys. We do means at the time of organ harvesting, these kidneys from marginal donors are not transplanted because of their inadequate quality. Okay, so but nowadays, because of availability of various potent drugs and by specific treatment protocols, nowadays we are using these marginal donors. So that is one of the newer developments that happened in the field of transplantation. That is the use of marginal donors and expanded criteria donors. And the second important thing is the dual kidney transplantation. So previously in olden days, similarly to that of the marginal kidney donor or any pediatric donor, when the child is dying because of some road traffic accident or some other cause, some cerebral cause or brain-related disease. So these organs they used to get discarded because of lower kidney size and lower renal mass and lower nephron mass. But because of availability or because of implementation of dual kidney transplantation, both kidneys can be transplanted into a single recipient. Normally in cadaver donors, the two kidneys are separated and each kidney is transplanted into a different individual. That means two recipients, they get kidney from a single donor. So in case of dual kidney transplantation, we can transplant both kidneys into a single recipient, especially if the donor is a pediatric donor or a marginal kidney donor. So that is also a newer development. Another field is the doing incompatible transplantation. So the word incompatibility means it is not matching. So normally in case of organ transplantation, both the donor and recipient or both are matched with regard to two things. One is blood group matching, and there is HLA antigen matching. So blood group matching, for a brief note, we'll discuss the brief. If you see the blood groups, we have 4 different blood groups. Okay, A, B, AB, and O. So if you see A group individuals, they have A antigen on the surface of RBCs or the other tissues, and the blood or the serum has anti-B antibodies. Similarly, opposite thing happens in B group. B group has B group antigen and anti-antibodies in the serum, and O group has no antigen on the RBC, but both types of antigen serum. AB is opposite to that of that. So this is the normal basic blood group system of the humans. So in case of blood group matching, if you see the compatible matched groups, O group is considered as the universal donor. They can donate to any group individual because they do not express antigens on the surface of RBC. Similarly, AB group is considered as the universal recipient because they can take organ from any group individuals because they do not express antibodies in the serum, because AB group has both types of antigens A and B on the surface of RBC and no antibodies in the serum. So because of no antibodies in the serum, they can receive the organ from any group individuals. So they are called as universal recipient, and the O group is called as universal donor. They can donate to anybody. So this is the normal compatibility in the organ transplantation, in the field of transplantation. So in case of incompatibility means doing the transplantation across these compatible groups. That is a ABO incompatible transplantation. In case of HLA incompatible transplantation, HLA antigens are the immune antigens which are expressed on surface of all types of cells, not only immune cells but also the kidney cells also. See, so each person has a different set of HLA antigens. So if the patient or the recipient is having antibodies against the HLA molecules of the donor organ, he can reject the organ or the graft immediately after transplantation. That is called HLA incompatibility. So in olden days, this ABO incompatibility or HLA incompatibility is a contraindication or not an indication for transplantation. But in recent days, because of availability of specific treatment protocols, we are doing now even this incompatible transplantation, both HLA incompatibility and the ABO incompatible transplantation, because of use of specific treatment protocols. We first deplete the presence of antibodies in the serum of the recipient and then do the transplantation so that the foreign organ or the donor organ is accepted in the recipient without any rejection. That is the incompatible transplantation. And another development is the swap transplantation. So swap transplantation, in brief words, is the exchange of organs between two or more different donor recipient pairs. So if you see the simple swap transplantation, if you see in this figure, there are two pairs of donors and recipients. Okay, one pair is having A group donor and the B group recipient. Another pair is having B group donor and the A group recipient. So normally they are incompatible to each. Within the group, they are incompatible to each other. Their donor they cannot give to their recipient. So if you exchange the organs between these two groups, so these two transplants can be done and with a compatible pair. So that is the exchange of organs. In simple terms, this is a swap transplantation. We can exchange between the organs not only between two groups but in more number of groups also. In India, it's now picking up. That is a swap transplantation. That is also a newer development of transplantation. And there is transplantation from non-heart beating donors. So normally we do transplantation or the cadaveric transplantation usually taken from the donors from brain death donors where the heart is still beating. So the non-heart beating donors are the donation after cardiac death, which is called as DCD, donation after cardiac death, is now picking up. So even after circulatory arrest or the cardiac arrest, even if the heart is still not beating, we can transplant within a window period safely by using potent induction agents like ATG. So that is also one of the newer developments in the field of transplantation. So actually this is a live program. So while we discuss regarding this topic, we try to answer the questions which are asked online. So we'll see a few questions which are asked online. So can a male patient receives a female kidney? Okay. So this is one important question. Actually, in India, if you see, take 100 transplants, almost 80 transplants, they are between female donor and the male recipients. The most of the kidney patients, they are actually male recipients because renal failure is more common in males. So, and in India, most of the donors are wives or the mothers. So in India, it's quite common that mothers or the wives are donating to the respective male partner. Okay,
That is quite common. So this is relatively safe, and almost 80% of transplants, they occur like this only. Remaining 10%, where the female partner is affected, like husband is donating to the wife, that is actually a high risk transplantation. When the female is donating to the male, it's not a high risk, but the male person is donating to females, it's a high risk transplant, because during pregnancy, the female lady or the wife is already exposed to the antigens of the husband. So while transplantation, so in this case, the wife is already exposed to the husband antigens. So lady develops the antibodies against the husband antigens already in these cases, usually in pregnancies. So if again if she receives the graft or the organ from the husband, there is high chance of rejection, or the graft is means it may function subnormally. So this is a high risk of transplant. But the female to the male recipient is quite common and is completely safe. So there is a question, there is the answer to the question. Okay, we'll see the next question. So what tests are done before transplantation? Okay, so transplantation, actually it's a huge topic. We cannot discuss this single topic in this small session. So tests, actually I have already told regarding the compatibility. The two incompatible things we have to match between the donor and recipient are the blood group compatibility. That means I said your O group is the universal donor, AB group is the universal recipient, and so apart from this, the blood group should be matched. Okay, so that is a compatible blood group pairs. So there are different compatible blood group pairs, so that should be matched, blood group should be matched. Okay, and second thing is the HLA matching or the cross match should be negative. These two are the important things which need to be tested before transplantation, apart from the other routine tests which are routinely done for both donor and recipient, like cardiac evaluation or the psychiatric evaluation or the even the renal system evaluation. All these things are the general tests, but this blood group matching and the HLA matching or the cross match test are the most important tests, are the most important things which need to be verified before transplantation. What HLA compatibility, as already discussed, HLA antigens are the specific antigens which are expressed on surface of immune cells and kidney cells and any type of, all types of cells, almost all types of cells. It has again different types, HLA class 1, class 2, again it has subtypes also. So but broadly this HLA system to be matched, okay, between the donor and recipient. Even though there is no matching of HLA antigens, at least the recipient or the receiving individual should not have antibodies against the HLA of the donor antigens. Because if already antibodies are already present against the donor HLA molecules, there is high risk of high chances of getting the graft getting rejected. So that can be identified before transplantation by doing cross-match test. But cross-match test identifies only the pre-existing antibodies. Sometimes after transplantation, the antibodies can form de novo. That means after transplantation, the antibodies are formed newly after transplantation because of after exposure to the donor antigens, our body tries to produce antibodies against the donor antigens. So this de novo development of antibodies can also cause rejection. So by using specific immunosuppressive medicines, especially the three important drugs which we use are cyclosporine tacrolimus, steroids, and mycophenolate mofetil or azathioprine. These three important drugs which act at different levels of immune system. They try to suppress our immune system. They try to suppress the production of antibodies against the donor antigens, so that the graft is function normally without the body getting without the body rejecting the graft. So that is the two important tests that need to be done before transplantation. So next question. So does a kidney transplant shorten your life? Okay, normally I have already explained this. In kidney failure situation, when the kidney function reduces to less than 10% of normal, the person usually requires some form of renal replacement therapy. Renal replacement therapies are the therapies which are directed and which are targeted mainly to replace the lost kidney function. So these therapies mainly include, on one side, dialysis therapies, on the other side is kidney transplantation.
So dialysis therapies actually, in truly speaking, they are actually ineffective. They contribute only to some percentage of the kidney function or the toxin removal. So they are not equal to the actual kidney function. So, but all patients, they may not receive the kidney transplantation. So dialysis, at least it prolongs the survival of the patient. But comparing the transplantation and dialysis, transplantation is always superior and the best option for kidney failure patients. Okay, if there is no contraindication. So kidney transplantation has the highest survival rates and the best quality of life in kidney failure patients. So if you take the survival rates, as I already told you, the 5-year survival is more than 95% for kidney transplantation, and 10-year survival, if you see, it's almost 85 to 90% in kidney transplantation. If you see the dialysis on the other aspect, the 5-year survival is very less. It's almost only 35 to 40%. If you take 10-year survival, is almost just 10 to 15% only. So the survival rates and the quality of life are much better for kidney transplantation. So that's why throughout the world or globally, it is said that kidney transplantation is the best form of therapy for kidney failure patients rather than dialysis. So the survival rates are much better for kidney transplantation. Okay. So we'll see the next question. So after kidney transplantation, what are the diet restrictions? Okay. So diet restrictions, okay. Actually, truly speaking, there is no diet restriction for kidney transplantation, and the restrictions are depending on the actual graft function. So how the kidney, new kidney or the graft is functioning. If it is functioning normally, usually there are no diet restrictions except for some amount of salt restriction and some amount of fat restriction. That is a healthy diet. Okay. Because the transplantation drugs, what we use, like steroids or the cyclosporine tacrolimus or the mycophenolate mofetil, they have their own side effects. They can cause obesity, they can cause bone mineral density loss, all those things, and they can cause a lot of infections and immunosuppression, all those things. So because of that, we need to, and they can cause hyperkalemia and hypertension sometimes. So depending on the graft function and depending on the electrolyte imbalance, usually some amount of salt restriction is required. Other than that, usually there's no diet restriction. If the patient is having some hyperkalemia, we need to restrict the potassium rich diet also. But other than that, there's no diet restriction usually. But they have to eat well cooked and clean food. Okay, even the water should be very neat because they are at risk of infections, and uncooked or unclean things should not be done. And they have to wash their hands. That is a routine things we will explain at the time of transplantation to the recipient, how to take care of their these things, general things. We usually counsel them. Okay, so general principle is there's no much diet restrictions after transplantation, except thing is they have to take clean diet. That is the most important thing. In case of dialysis patients, they need to restrict a lot, especially the water, salt, or the potassium-rich food. All those things need to be restricted very much in dialysis patients. In transplantation, the quality of life is very good, and there are no much restrictions in a general principle. Okay. Okay. So another person is asking about transplantation from animals. Okay. So actually, there is a recent developments. I forgot to mention. Development is happening in the field of xenotransplantation. Xenotransplantation means where because of disparity in the available organs and the demand. So if you see the demand versus the availability of organs, the demand is very huge. Many patients are in wait list for transplantation. Okay, if you see the Jivandan program, almost 3,000 to 4,000 patients, they are waiting for the organs or the deceased donor organs. So the demand is very high. On the other side, the availability organs is very less. So to reduce this gap, there are several options we are searching for. One of them is xenotransplantation. Especially the organs are taken off from porks. There is a porcine kidneys. So in other way, it's pigs. So pig kidneys are being tested or under development for use for human use. Okay, there are still it's in pipeline. It's still in development. It takes several more years, I think, for it to become a clinical practice to use xenotransplantation. It has its own disadvantages and side effects and loss of logistic and issues are there. So it's still in development. It's not into clinical practice. The process of xenotransplantation from porcine kidneys. Okay. So next question we'll see. So what is preemptive transplantation? Okay. So actually preemptive transplantation means doing transplantation without undergoing dialysis. That is a preemptive transplantation. So usually this preemptive transplantation is done when the patient is on regular follow-up with the nephrologist, and when the kidney function, native kidney function, goes down to a severe level, usually less than 10% of the normal kidney function. At that stage, the patient or the recipient requires some form of renal replacement therapy. So some patients, they can go directly for the renal transplantation without undergoing dialysis in between. So that is the actual preemptive transplantation. Okay. So many patients, if they have good already available donor and the good they already arranged finances, they directly go for the transplantation directly with 1 or 2 dialysis before transplantation, or even sometimes even before, without any dialysis also. So these are considered as preemptive transplantation, and in various studies it has been shown that preemptive transplantation has a much more higher success rates compared to the routine transplantation which are done after a period of dialysis. And it has been said that before transplantation, the longevity of the dialysis has a bad impact on the post-transplant outcome. That means if one patient is has received more years of dialysis before transplantation, they do much lesser compared to the preemptive transplantation recipients. So they do more badly compared to the preemptive transplant recipients. So the duration of dialysis should be very minimum, and that is the idea of preemptive transplantation. Okay. So especially children, it's much more useful, the preemptive transplantation, and the benefits are much higher compared to the routine transplantation. Okay. So we'll go to the next question. So what is the kidney bioengineering? Okay. So actually, I think somebody has read in newspapers or in internet. So kidney bioengineering is a newer development where the kidney is manufactured artificially by using various scaffolds of the kidney, either from animal or the dying human kidneys. They are taken out, they are decellularized. That means the kidney cells are removed by a specific process, and the background scaffold is used. And after on the top of this scaffold, the stem cells are developed. So they are procured from the human tissue, and these stem cells are procured, and they have created a bioartificial kidney. And in animal experiments, it has worked well. So, but it's still in primitive or the primitive stage of development. It takes, I think, several years or even decades also. It requires further fine-tune of the development. So the kidney bioengineering or the manufacturing of artificial kidney is still experimental stage. It's not into the clinical or the human use, and it may take several years. I think it's not conclusive. Okay, so we'll see the next question. So what is tolerance in kidney transplantation? Okay. So tolerance, actually, it's a scientific word. Okay. So tolerance is for layman people or the general public, it's a difficult to understand phenomenon. Tolerance is a phenomenon where the graft or the donor kidney is accepted in the recipient without much need of the immunosuppression. So normally, after transplantation, we give various forms of immunosuppressive drugs to protect the graft or to prevent the rejection of the graft from within the recipient. Okay, normally the recipient immune system tries to reject any foreign organ or foreign tissue by development of antibodies against the donor organ. So this is prevented by using special medicines. As in case of tolerance, the graft is protected from the immune system without much use of immunosuppressive medications. This is also there are various processes for induction of tolerance. Most important is the stem cell transplantation. That is a production of a phenomenon called as chimerism in the recipient. So that is the most important thing in development of transplantation tolerance. And the various drugs are being used like belatacept and all those things. or they are in pipeline for induction of this tolerance. And the tolerance is actually holy grail in the field of transplantation. So if you achieve transplantation, is well and good, because you don't require any drugs, immunosuppressive drugs, and the graft is taken well placed and with a good functioning graft. Okay, so we have almost all discussed all the newer developments in the field of transplantation, in the innovations in the field of transplantation, like swab transplantation, HLA incompatible transplantation, ABO incompatible transplantation, use of marginal kidneys, dual kidney transplantation, transplantation tolerance, induction of chimerism, and kidney bioengineering, and xenotransplantation. So all these things are, most of them are covered in this live program. So I thank you all. So we'll meet at some other time. Thank you very much.